And let's go ahead and get going. So we're going to first talk about pain and comfort. So as you all know, pain is critically important in the management of our older adults, as it is with any patient that we take care of. It is the fifth vital sign. It is a key quality indicator in the acute care and nursing home setting. So for those of you who are interested in working with the geriatric population, specifically in the nursing home, pain is going to be very important as a quality indicator of the care that you provide. And even for those who do not specifically want to work in the long-term or nursing home setting, in the acute care setting, it's going to be a very important indicator of how you manage your patients. It's monitored by governing bodies such as JCAHO. Your clinical performance is going to be monitored in part by how well you manage pain in your patients. So it's something that we all want to pay attention to, monitor very closely for, assess very closely, and manage, as best we can in the older adult. Undertreated pain in older adults is common, and it's especially common in those of color and those who are cognitively impaired. And if you think back to our last group presentation, one of our groups did a very, very good presentation on people of color and how there are inequities in the way that they're managed. So pain is just another one of those areas of clinical care where there are inequities based on race and things of that nature. So pain in the older adults can be especially concerning at the end of life. When people are at the end of life, which we'll talk about more next week, this is a time when we want individuals to be most dignified, most comfortable, and pain is definitely something we do not want those who are at the end of life to be experiencing. So a comprehensive multifactorial assessment is very important with the interdisciplinary team, including those who are specialists in pain management, which we'll talk about a little bit later. So there are different types of pain. There's acute pain, which is temporary, usually related to either a traumatic event or a procedure, and it's usually quite easily managed with analgesics. And then there's persistent pain that doesn't really have a time frame, and it has varying levels of intensity. And when I'm going over these slides, I thought back a couple of years ago, I had a couple of you in a long-term care facility for clinical, and I don't know, Sylvie, I hate to call you out, but I remember, Sylvie, that you had a patient with me who had persistent pain. I think he had had a car accident, and he kept saying that he was in pain, and the nurses at the long-term care facility sort of gave him his pain medication on a every 4-hour basis. And he never really left my psyche because he kept saying to you, I have this pain 24 hours a day. It never goes away. And you were trying your best to do such a good assessment, and you were asking him, like, are you still in pain? He's like, I'm always in pain. So I thought back to him when I was looking at this lecture. But that's a type of pain, like persistent pain. Patients actually get to a point where they learn how to live with it. And they sort of stay on a pain regimen, usually something that's long acting in addition to breakthrough pain medication. But it could be related to multiple things. Some other causes of pain that are non-cancer related in older adults could be inflammatory pain like arthritis, individuals who have degenerative spinal conditions, neuropathic pain from things like diabetes or herpes. And so some of the consequences of pain, I mean, there are many, and you'll see that there are several slides that just go over the consequences of pain in the older adult, but some of them are easy to imagine, falls and accidents, right? Because if you're in pain, you can't move as appropriately as you'd like to. Your gait might be not as steady or as supported or as stable as it should be if you're dealing with pain. Of course, there's functional impairments. It's going to slow your rehab and recovery. Sleep disturbance, definitely. If you're in pain 24 hours a day, you're not able to get good rest. And that's especially important when we think back to the lecture last week on depression. And can anyone remember what one of the key main causes of suicide in older adults were? if anybody remembers, you can just put as a comment, what was one of the leading causes of suicide among older adults? Exactly, Jessica, exactly right. Sleep disturbance, insomnia. And so thinking about that, you realize that these consequences of pain have secondary consequences that we definitely want to treat and be aware of. And it just gives us another reason for making pain number one on our priorities. You know, going on, changes in nutritional status, impaired cognition, increased dependency and helplessness. And if you think back to our one of our earlier lectures, I won't give you too many clues. Why would dependency, increased dependency and helplessness be something we really want to avoid in the older adult? To do with one of our earlier lectures. Think back, pre-COVID, when we were actually in the classroom. Yes, you want to maintain independence, but there's something that those who are highly dependent patients have a risk for something that we definitely want to avoid in our older adults. Yes, Brianna, you're exactly right. Risk for abuse. Brianna got it, Alexandra got it, and Carly got it. So anytime patients who have higher levels of dependency and helplessness are at higher risk for elder abuse, as well as those with impaired cognition. So again, just highlighting those secondary consequences of pain. Just again, making further impressing upon us why we want to make it so high on our priorities when we're assessing patients. So pain in cognitively impaired elders is a special challenge because communication can sometimes be hindered when somebody isn't able to clearly communicate to you what they're feeling, how they're feeling, if they're in pain, where they're feeling the pain, how bad the pain is. And so these patients are at high risk for consistently untreated or undertreated pain just because that communication line is broken. So careful observation and caregiver reports need to be used. So really relying heavily on those family and friends who spend a lot of time with the patient as their caregiver can be helpful in giving a better assessment of what's going on with the patient so that way you can take the best care of them. Nonverbal expressions of pain, behavioral changes, wincing, um, retracting, sort of supporting a particular area, pointing at a particular area, focusing on a particular area might highlight that something is wrong there, that they might have pain in that area. Changes in their activities of daily living. If somebody was previously up and out of bed and able to get to the bathroom and to the day room or wherever, and now suddenly they're more reticent to get up and move on their own, then you might want to investigate what's going on. Is there something physically that's going on that's hindering you from moving? Are you in pain? Of course, vocalizations, and they might not always be appropriate. Maybe it's screaming down the hallway, I need help, I need help, I'm in pain. We had a patient like that 2 years ago, I think, at the VA, who was in so much pain. He was screaming and he was literally got out of the bed and was on his knees, like praying because he was in so much pain. And he was especially complicated because he had a history of narcotic misuse. And so the team was very hesitant to treat his pain with narcotics, and that just made the whole thing so much worse. But he had a very, very overt, obvious expression of pain vocally. And then there's physical changes. If you see, a limb doesn't look right or uneven, maybe there was a fracture there or something, where even if somebody can't verbally express they're in pain, you can see that there's something wrong, and that might lead you to investigate further. There are also pain scales that are developed specifically for people who have cognitive impairment, and two of them are the PAIN-AD, which is Pain Assessment in Advanced Dementia, and the PACSLAC, which is the Pain Assessment Checklist for seniors with limited ability to communicate. There are several mnemonics for pain assessment. This first one, the old cards, is actually a good mnemonic for assessing really anything, anything from pain to psychological symptoms, any symptom at all, I like this mnemonic because it helps you to capture all the relevant details of that symptom. So when did it start, the onset, where is it, where's the location, how long has it been going on, and also with duration, is it intermittent or is it constant? What are the characteristics? Is it burning? Is it stabbing? Is it pinching? Is it aching? Is it cramping? What makes it better? Relieving factors, anything that makes it worse, and treatments that have been previously tried. Another mnemonic is just more of an approach to pain management, and it's a way of trying to be as comprehensive as possible. And so it always starts with believing the patient. Never assume that the patient is lying, or, there's sometimes you have patients who have a history of drug seeking or misuse, but even in those cases, you always want to start from a place of believing the patient when they say that they're in pain. You want to ask about pain regularly. And now that could be every shift, that could be every encounter that you have with the patient, that could be every couple of hours, that could be, certainly after you've treated a patient for pain, you want to come back within 1 to 2 hours, whatever your institution's policy is, to reassess and make sure that the treatment that you gave them worked and that the pain is getting better. You monitor for isolation, whether it's psychological or social issues that are going on. You want to notice nonverbal signs of pain. You want to evaluate the pain characteristics, whether that's using the old carts or any other method for assessing pain. And then you want to assess whether or not the pain impairs the patient's function. Some of the treatment modalities for pain, there are a number of them, and they start with drugs that are non-opioids, which are some of the best options, especially for older adults and older adults who have cognitive impairment. Acetaminophen is always a great first choice to begin with, and I think that this is a more appropriate option for this sort of mild soreness, pain that's maybe rated between a 1 to a 4, pain, that really isn't that severe. With the acetaminophen, you just have to be sure to make sure that the patient doesn't take more than 4 grams in a 24-hour period, and that's from all sources. So consider drugs like Percocet that include acetaminophen in it, that you have to keep that part of those. And then you want to monitor renal and hepatic function. NSAIDs are on the Beers list, so they do have adverse drug events in older adults, and it's a drug that we would use more cautiously in the older adult. The other thing to keep in mind is many of our older adults are on aspirin for cardioprotective effect, but the thing to keep in mind is when you're taking aspirin at an NSAID, you can reduce the cardioprotective effect of the aspirin. And then we have the opioid analgesics, which are a little bit more risky. Certainly, many of these drugs are Beers list medications. It doesn't mean that you can't use them. It just means that you have to be more cautious when using them in the older adult. Demerol is one of those drugs that are actually contraindicated in the older adult. And I feel like in general practice, we're moving away from Demerol just because of some of the data that's been out there about its risk for CNS issues. But again, you want to begin with a short-acting, low-dose narcotic analgesic if you're going to use one, and then titrate up to best response. Some of the age-related changes may produce a greater analgesic effect and a higher peak and a longer duration of effect. And that's if somebody has changes in their hepatorenal function that may make it take longer for the drug to be processed. You want to assess closely for sedation, respiratory depression, and impaired cognition with these medications. And so what I used to do when I was on the floor and a patient needed a narcotic or an opioid analgesic at nighttime when I was working nights, that was the patient that I kept close eyes on. I would teach and educate the patient, okay, here is your oxycodone, let's say. Make sure that if you want to get out of bed for any reason, you call. And that would be especially for patients who were ambulatory, out of bed ad lib. Even if they are ambulatory out of bed, if they're taking an opioid analgesic, especially at nighttime, I would still have them call to get out of bed and get assistance out of bed. And not only would I teach that to the patient, I would also talk to the PCT who's assigned to the patient and make sure they're aware of that too, because there's a higher risk for falls and injury. And pain management consult is always a great option for pain that is unrelieved with opioid analgesics, and also for patients who are just more complicated, who have dementia or cognition issues, where it's just a little bit more tricky to manage their pain while avoiding exacerbating their mental health or cognition issues, or for patients who have history of abuse, narcotic abuse, or drug abuse or alcohol abuse or anything like that, then having a pain consult can be very helpful. Oh, I'm sorry about this, the layout here. But here we're just talking about adjuvant drugs that you can use, drugs that are not necessarily drugs specifically for pain management, but that can be a nice adjunct to a pain regimen to help keep patients comfortable. And that can include drugs like tricyclics for neuropathic pain. The thing is, you just want to avoid drugs that precipitate or potentiate extrapyramidal symptoms, which includes drugs like Haldol, for instance. Corticosteroids, I think, are excellent drugs, especially for inflammatory-related pain like arthritis. I found that it's been extremely helpful for patients with gout, for patients who have any kind of tumor-related pain, like those who have cancer, who have spinal cord impingement from their disease. Corticosteroids can be very helpful in reducing the size of the mass and allowing it to reduce the impingement on the nerves and lessen pain. So I think that they make a very, very nice adjunct, if not used alone for pain management. Oh, somebody's touching the slides. Guys, remember, do not touch the slides. It's just going to delay us getting through this. Okay. And then there's topical analgesics like lidocaine patches that could be very helpful, and muscle relaxants. This is a copy of the World Health Organization 3-step analgesic ladder. This, as you can see from the citation, is from 1996. I did a quick search just to make sure it wasn't updated since that time, and it looks like this is still their standard. So you want to start with non-adjuvant, non-opioids or adjuvant pain medications like acetaminophen. And if the pain is increasing, you kind of go up from there to opioids and sometimes using longer acting opioids in addition to fast acting opioids. So this is just, it's not important for you to memorize this, but it's just good to understand sort of how pain management is best addressed by starting low and sort of slowly graduating to the patient's tolerance and to the best effect in terms of managing the pain. Then there's also non-pharmacological options like touch therapy, acupuncture, relaxation, meditation, cognitive behavioral therapy, and activity like exercise, light walking, yoga, stretching that can also be helpful for pain. Another thing that I don't see here is heat therapy. Like some patients have had like aching or soreness, for instance, after having a central line placed, where just a warm pack can be very helpful. So heat and ice therapy can sometimes be a nice low-risk adjunct to pain. And then, of course, pain clinics managed by pain and palliative care specialists who are very, very helpful in managing pain that's more complex, a little more complicated than what can be managed by a primary care doctor or non-specialist. So how do we promote good pain management as nurses? Experience of pain, just understanding that the pain is multifactorial with physical, psychological, and spiritual components, that it's subjective and that it's unique to each person. So again, going back to believing your patient, and pain is whatever the patient says it is. Perform a careful, thorough assessment. It is never acceptable to fail to treat pain to the extent possible. Keeping in mind both traditional and complementary therapies because they oftentimes do work very well together. and performing frequent assessment of qualitative and quantitative levels of perceived pain by your patient, and assessing for adequate relief of pain once you've intervened. So now we're going to move and talk about nutrition and hydration. There's a lot of crossover between this lecture. It's more or less a review of what we went over when we talked about the GI tract and the renal system. But so I won't, harp on too much of this too much. I'll sort of do a nice review. But of course, adequate nutrition is a key factor in maintaining health in older adults. An adequate diet is very important, not only for general health and nutrition, but also it helps in delaying the onset and managing chronic illnesses associated with aging. Proper nutrition includes all the essential nutrients, including carbohydrates, fat, protein, vitamins, minerals, and water. I find that the American diet can oftentimes be heavily focused on carbohydrates and fat, and that can also oftentimes lead to obesity. So understanding the micro and macronutrients of your patient's diet can be very helpful in doing appropriate teaching and helping them to adapt a diet that's a little bit healthier and that's going to be more healing for them and nutritive for them. This is a copy of the modified pyramid, dietary pyramid for older adults. And it emphasizes not only diet, but also regular physical exercise. It provides the types and amount of food to provide adequate nutrient intake. It also has a nice emphasis on intake of fluid and water, which we're going to talk more about hydration in a moment. And it reminds older adults that supplements may be needed for adequate calcium, vitamin D, and vitamin B12. And thinking about back to our safety lecture, why are vitamins like calcium and vitamin D very important? Both I reviewed it and your class presenters on falls reviewed it. I think I might have just given you the answer, but both is vitamin D important? Bone health, exactly. And risk for falls. Very good, Raven. So this is just a breakdown of the composition of nutrients that should be part of the diet. So 25 to 35% fat, it should be about 45 to 65% carbohydrates, and that's because the carbohydrates help to provide us with energy, and so that's why the diet is very heavily made up of carbohydrates. Protein is also very important. It's 10 to 35% of the diet. And fiber should increase to 14 grams per 1,000 calories. And then this is just reiterating again that you have a nice balance of vitamins and minerals as well. And so overnutrition is not a good thing. That can lead to obesity, which can exacerbate chronic conditions. And it also may affect functional status in older adults with sarcopenia and osteoporosis. And it can lead to a higher workload for caregivers when a patient is obese. So again, focusing on what the diet should include, the breakdown of carbohydrates and fats and minerals is important, and understanding what your patient is eating and what is their breakdown of different macronutrients, because then you can help to guide them in terms of how they can make changes that are healthier. And you also don't have to do this alone. Nutritionists and dietitians can be very helpful in making these assessments and managing patients' diets with you. So malnutrition, there's a rising incidence in the acute care, long-term care, and community. Institutionalized older adults are at highest risk, and that's because they're not able to eat the type of food that they would normally be able to eat. Not only because they're sometimes on medically prescribed diets like NPO or clear liquids for prolonged periods of time, depending upon what they're in the hospital for, but hospital food is not always appealing. And so some patients are hesitant to really eat the food that's in the hospital. So what are some things that you think that we can do for a patient who's just not really into the food that's available to them in the hospital, but you want them to maintain their nutrients? Yeah, you can ask what foods they like. What else? Exactly, Monica. That's exactly it. And Porn Pen got it too. So asking family members to bring in food. I used to do this all the time. When I was working as a floor nurse years ago, I was on the floor where the patients were in the hospital for a very long time, oftentimes 2 weeks plus. And so while the food in the hospital wasn't bad, it's after a while having the same thing, the same rotation of foods over and over again, patients got tired of it. And so what I would oftentimes do is talk to them about having family members bring food in. We had a microwave in our kitchen where we can heat food up for them, and the dietary services can be helpful with that too. So never hesitate to ask family members to bring in food. Let me see. What if the food from home is not necessary? Oh, yeah, that's a good question. And so we got a question about what if the food that the family wants to bring in is not the healthiest? Like, what if they want to bring in McDonald's or Shake Shack? Or the diet that the family member eats at home, if it's highly concentrated in carbohydrates and fat, like a lot of rice and fried beans and fried food like that, then that's where education is very helpful. And so I think for something like that, that's not only important just while they're in the hospital and trying to get them to have foods that's more appealing in the hospital, but that's teaching that you can start in the hospital, that they should continue when they get home. And I would get the dietitian involved and help them talk to the family about ways to make their foods that they like in a healthier way. So for instance, maybe grilling chicken instead of frying it. Um, Maybe baking beans instead of having fried beans. And it takes a lot of um, commitment because it's hard to make those changes. If you like eating a certain way, it's hard to change. But I think with a lot of education about why it's important to eat healthier and to try to change your diet to a healthier diet, I think can get patients and their families on board. But I think that's a great question. I think that's a great thing to think about. But having the nutrition and the dietitians help play a role in assessing and talking to the family members about how to make changes with their diet. And I think that having them bring the food in also opens up an opportunity because then you can see the kind of food that they're probably eating at home so that you can make that assessment and manage it and try to get on top of it while they're in the hospital before they go home. So there's a lot of benefits to having the patient's family bring in food if that's allowed in your place of work. But again, with malnutrition, getting back to that and some of the risks, we've touched upon this over the course of the class, over the course of this class, but pressure ulcers, especially when you're not having enough protein in the diet, anemia, hip fractures, hypotension, impaired cognition, overall increased morbidity and mortality. So doing comprehensive screening and assessment very important. And again, it's not something you have to do alone. Trying to get the nutritionists and the dietitians to work with you on this is very helpful. So factors affecting the fulfillment of nutritional needs, age-associated changes in taste and smell can make food less appealing. Oral health status, which we're going to talk about a little bit more. Chronic diseases and conditions, and especially if it's a chronic disease that causes a lot of fatigue, because eating a meal takes a lot of energy. So keeping that in mind. So if somebody has, say, CHF or COPD or cancer, where they're very prone to fatigue and fatiguing with minimal activity, then you're going to want to advise them, instead of trying to sit down and eat 3 big meals like a breakfast of eggs and toast and a little cereal and orange juice, and then a lunch and then a big dinner, maybe it's easier for them to have smaller, lighter meals over the course of the day. And keeping track of what they're eating, again, so that way you can see what's their balance of nutrients, of the macro and the micronutrients and calories. So that way, even if they are eating smaller, lighter meals throughout the day, you want to make sure that they're still getting in everything that they need. Side effects of medications can certainly play a role. Lifelong eating habits, which we just talked about. Socialization, the loss of a loved one, of friends, being in an isolated environment, in a nursing home, which is increasingly an issue now, can make it harder for someone to really want to eat as much as they used to. So keeping that in mind, maybe if you are in a long-term care facility, once we get out of this situation that we're in with COVID, but finding ways to make mealtime social with residents, so that way, even if they don't have friends and family who are able to come and frequently visit with them, mealtime can still be a social event. And I found that this was especially evident during clinical, when I was in the long-term care facility. The patients would love when you guys would come to take care of them, because when they would otherwise be alone and eating by themselves, they had you, the students, who were happy to spend time with them and help them set up their bed and get washed up and then have their meal. So, there is an important role that's played by just having volunteers and nursing students who can spend that extra time with the patient. And then, of course, there's anorexia of aging. Income can play a heavy role. If you can't afford to eat healthy foods, that could, certainly affect your diet. Transportation and not being able to go out and shop on your own. But there's great resources out there like Meals on Wheels that can be helpful for people who are in this situation. And then, of course, those who have unstable housing, then they have a lot of issues that can make nutrition very, very complicated. And so patients who are hospitalized or in institutional living are at highest risk for malnutrition. And we kind of touched upon this already between the restricted diets and PO status or clear liquid status, and then just not really liking the food that's available and insufficient time for feeding assistants. In the nursing home especially, you've seen how patients, oftentimes there's one nursing assistant or two nursing assistants for 40 or more patients. And so getting to each patient and helping them to eat their meals on time before they get cold and are really not appealing is hard. So it's a team approach. Maybe the nurse is helping out when they can, or again, volunteers or nursing students can be helpful in this situation as well. And so what else can we do to improve the nutritional status of our institutionalized patients? Getting family involved, as we talked about, use of nutritionally dense supplements with medication pass. And so by this, they're meaning like instead of just giving the patient their pills with a little bit of water, maybe using a little bit of boost or resource if it's not contraindicated with the medication. I think it is a good idea. But even using Ensure and Boost outside of just medication pass, just as a supplement throughout the day, can be a good idea. And then, of course, creating a social and a appealing eating environment for patients. Consideration of ethnic food choices is important. Liberal food diets when you can. Finger foods, visually appealing pureed foods if a patient's on a pureed diet. And making snacks and fluid easily accessible. And so establishing routine for meals and snacks consistent with a accustomed eating schedule can be helpful, especially for those who are cognitively impaired. Frequent changes can throw them off and make it harder for them to establish good nutrition patterns. We talked about incorporating favorite foods, visual cueing, and handover assistance as needed for those patients who need to be fed. Appropriate utensils and dinnerware. I've seen it many times, and I'm sure a few of you have too, where the tray is sent up with no utensils. So that's not good. So just making sure that the patients have what they need to eat their meals. Offering fluids in between bites of food, and that's because, as we talked about in the GI lecture, there's less oral secretions as you get older, and so you have a higher risk of aspirating or choking, especially for eating large boluses of food. So making sure you have sips of fluid in between bites, and that they don't take in too much of a large bolus, small amount, and taking small bites at a time. Eliminating distractions and allowing time for older persons to enjoy and to complete their meal. I know they're on tight schedules, especially in the hospital. They have to go to this procedure, then there's rounds, then they have this x-ray, or they have this or that, they have PT, but trying to carve out that time so that they can really enjoy their meal and take their time goes a long way. Just going on more with those in the institutional setting, it's estimated that 50% of all residents are unable to eat independently and they need to be fed. So again, going back to staffing issues, if there's not enough techs to help every single patient eat their meal in a timely manner, that can certainly complicate their nutrition. Restrictive diets and poor use of supplements further affect nutritional status. So keeping in mind those things like Ensure and Boost is very helpful. And if somebody is on a restrictive diet, remembering to get the restriction lifted as soon as possible. So if you pick up a patient post-op and they're now swallowing, they're out of the operative recovery room, reminding the team to put in a regular diet and to DC the NPO or clear liquid diet so that way the patient can order meals. Sometimes that gets left and the providers forget to resume the regular diet after a procedure. So sort of staying on top of that and making sure that their diets are resumed will be very helpful. And so always going back to assessment, nutritional screening, there are several screening tools available, which I think we covered in the GI lecture. The minimum data set includes risk factors and triggers for further evaluation, interview and physical exam. We talked about anthropometrical measurements, biochemical evaluations, including chemistries, and then different interventions that can help. Pharmacological therapy. There are some drugs that are out there to help stimulate appetite, like there is the oral form of marijuana, the Marinol, which I don't know, I feel like the results of that are mixed. Some people find that it is very helpful in stimulating their appetite, some people don't. And another drug is olanzapine, which is actually a drug for depression, but we do use it because it has shown evidence of helping to stimulate appetite and actually alleviate nausea as well. This is just data that I've seen in the cancer population. So I don't know that you'll see those agents used in the general population quite as much, but also with consideration of pharmacological therapy, there are some medications that can affect nutritional status. So just being aware of all the medications that your patients are on and working with the pharmacist and the medical team to try to decrease the impact of the medications that your patient are taking to their nutritional status, and then doing education with the patient and their family about their medications, as well as ways to optimize their nutrition is always important. So now we're going to switch gears a little bit and talk about hydration management. Adequate fluid consumption and maintenance of fluid balance is essential to health. Risk factors for changes in fluid balance include physiologic changes in body water content, impaired thirst sensation, medications, functional impairments, chronic illnesses, emotional illness, and high environmental temperatures. And so dehydration is a geriatric syndrome that's associated with disease and declining health in the frail elderly. It can exacerbate clinical conditions in the setting of infection, and it often can go misdiagnosed. Mortality for dehydration can reach as high as 50% if not treated. So some of the assessments for dehydration include a history of dehydration, history of infections or difficulty with swallowing, which can certainly hinder their ability to drink and hydrate orally. Any patient who has returned from a 24-hour hospitalization or even a same-day surgery, you want to assess them for dehydration because they've been fasting for a period of time. Monitoring the lab results, especially BUN and creatinine. Hematocrits can sometimes rise a little bit from a process called hemoconcentration, and that's just because there's less fluid in the body, so the hematocrit looks falsely elevated. Urine-specific gravity, and also another assessment is orthostatic hypotension, and that I see more frequently than most of these assessments, and that's just the patient gets up to stand up and they feel lightheaded. So I'm asking them, do you ever feel lightheaded or dizzy? And if they're saying to you, yes, especially like if I get out of bed or if I go from lying to sitting up, I feel a little dizzy, that could be a sign of dehydration. And so usually we'll get a set of orthostatic blood pressures, and sure enough, orthostatic, and usually we manage that by giving them IV hydration. Other symptoms of hydration requiring immediate interventions include fever, thirst, and warm skin, furrowed tongue, decreased urine output, and associated factors. Those who are 85 plus are at highest risk. Those who are immobile, those with cognitive impairments, and those who have fluid intake of less than 1,500 milliliters in a day And so usually I advise patients to try to stick to 2 liters of fluid a day, but I find for some that that's very difficult, especially people who are very small, who don't have a history of really drinking quite that much. Then I just tell them to kind of do the best they can and maybe get to even 1,500 milliliters is fine, but not to go much less than that. So going further in terms of assessment for dehydration, patients who are dehydrated have increased vulnerability to osteoporosis, heart failure, and dementia. Dietary restrictions of fluid, salt, potassium, and protein, like patients who are on dialysis, who have renal failure, or those with congestive heart failure, they are also at risk for dehydration. And then, of course, medications like diuretics especially, and laxatives can cause dehydration. So interventions, oral hydration, again, I encourage patients to try to reach 1,500 to 2 liters in a day. Replace 50% of loss within the first 12 hours or sufficient quantity to relieve tachycardia and hypotension. So again, starting with the assessment, doing a set of orthostatic vital signs can be very helpful in making the diagnosis of dehydration, and then hydrating and rechecking the orthostatics after the hydration to make sure the patient responds. Hypodermoclysis, where you give infusion of isotonic fluids into the subcutaneous space. This is very rare. I don't think I've actually ever seen this, but my guess is that you probably would see this type of treatment in the critical care setting. And then prevention is key. Doing great education to try to get patients to drink adequately regularly so that they don't get to the point of needing IV hydration or subcutaneous fluid infusions. Dysphagia is another common problem of the older adult that can affect their nutrition. As many as 60% of nursing home residents demonstrate clinical evidence of dysphagia. It is a serious problem with negative sequelae, including weight loss, malnutrition, dehydration, aspiration pneumonia, and even death. Some of the risk factors for dysphagia include stroke, Parkinson's disease, neuromuscular disorders, anatomical abnormalities, or cervical osteophytes. Other risk factors, oral or oropharyngeal cancer or surgery, laryngeal cancer or surgery, Alzheimer's disease and other related dementias, traumatic brain injury, tracheostomy, or aspiration pneumonia. So some of the signs and symptoms of dysphagia include difficult or labored breathing, drooling, copious secretions, aspiration, cough and choking at meals, which I find is actually the most common that I see is that this, not really choking, but just this sort of cough, almost like they're trying to clear their throat after they have a meal. Patients who are holding or pocketing food in their mouth, or patients who are not chewing when they eat. You especially find that with those who are really debilitated and weakened, who are often patients who need to be fed. Absence of swallowing, excessive throat clearing, as I mentioned, difficulty swallowing medications, wet or gurgling voice is also another common symptom, discomfort during swallowing, sensation or something stuck during swallowing. And I've heard patients complain of that a lot, where they just say, I feel like, I'll ask them, do you have pain in your throat? Do you have pain when you swallow? And it's not really pain, it's just like, I feel like thing is stuck. So that could definitely that's definitely a sign of dysphagia. Food or liquid coming from the nose during swallowing. And so some of the interventions for patients with dysphagia is having them sit at 90 degrees during all PO intake and maintaining a 90-degree position for at least an hour after their meals. Postural changes during meals, keeping suction equipment at all times, supervising meals, and monitoring temperatures, because of course one of the earliest signs of aspiration pneumonia could be fever. What are some of the other interventions you can think of for patients who have dysphagia? Anyone? What about consults? people, no distractions. Yes, very good, Carly. Any might be helpful to consult. Yes, speech and speech pathology, Alexandria, very right. PTOT, more speech, speech and swallow is very helpful. So very good. So yeah, speech therapists following their recommendations, getting them involved in the patient's care. Mouth care is very important. Visually checking the mouth for pocketing of food in the cheeks before and after meals. Doing mouth care before and after meals is very important too. Observing color of phlegm, really thick, yellow, greenish, purulent phlegm is not a good sign. That's usually a sign that there's white cell buildup in the secretions that are coming from the lungs, which is a sign of infection. So monitoring closely for that and asking about that when you're doing an assessment on a patient. If they're saying I cough and it is productive, what's the color of the sputum? And then neuromuscular stimulation. Feeding tubes is a treatment that's frequently used for patients with dysphagia, and its use has climbed over the years. I think oftentimes people find that this is the next step. If somebody has a difficulty with swallowing, then let's just put a tube in. And I was working as a nurse, I found that the doctors would move to putting in a tube very easily between a PEG tube or NG tubes, but actually feeding tubes come with a lot of risk. And so the recommendations are actually that a full comprehensive assessment be made before you get to the point of placing a tube. And that's because feeding tubes are associated with complications and risks such as aspiration pneumonia, metabolic problems, diarrhea, cellulitis, and they don't necessarily improve survival. They don't reduce incidence of pneumonia. They don't improve function, and they don't result in fewer pressure ulcers. So for all the risks that you're buying with placing a tube, the benefits just really haven't borne themselves out in the data. So when you have a patient who is having trouble with swallowing and with feeding, you want to really do a thorough assessment with the rest of the team and think about all of the factors that could be playing into the lack of nutrition between psychological factors, biological factors, cultural issues, because maybe there is room for improvement short of placing a tube. Maybe there are things that can be done to address those other underlying factors before placing a feeding tube. Up to 50% of patients with PEG placement die within 6 months of insertion. So again, assessment of all the factors that could be contributing to poor nutritional intake is very, very important. So that way you can try your best to intervene on one of those issues rather than just jumping right to placing a tube in a patient. But sometimes it can't be avoided, and a patient does need a feeding tube, whether it's a PEG or an NG tube. So if that is the case, then you just want to be careful in terms of how you're using it, in terms of how it's managed. And one of the big risks in terms of nursing management with a tube, especially with the NG tubes, which are very thin, is occlusion. And I have seen it many times, many times, where during medication administration, you have the drug, you try to grind them so that they're fine enough, but even with the best practice, I've seen it, I've done it myself, where I've been doing medication administration through an NGT, and the thing just gets clogged. And it's a big problem because placing an NG tube for a patient is obviously not comfortable. And so the worst thing in the world is that it gets clogged. You can unclog it, and then you have to take it out and put in another one. So just some rules of the road: do not add medication directly into a feeding formula. You want to administer each medication separately. You want to flush the tube before and after with water. You want to dilute solid or liquid medication as appropriate, and administer each medication using a clean oral or enteral syringe. Don't reuse, I won't say don't reuse it, but usually after a 24-hour period, we dump out all the equipment and get a new bulb syringe or what have you. Or if you find that it's just gunky and there's a lot of buildup in a syringe, then don't reuse it. Just get a new one. And so there is this Be Aware enteral feeding safety campaign here that just kind of goes through everything I just mentioned. But one thing I didn't mention was asking the pharmacist about drug-to-drug interactions, because of course you're grinding all the medications, and oftentimes you'll see the nurse just put everything into a cup, dilute it with water, and pour it down the tube. But just as you would with any type of oral medication, you want to make sure that you're not combining two medications that have a drug-to-drug interaction. So making sure that the drugs are compatible. Again, using water only to flush. Don't use a feeding solution as your flush. Um, Being careful and following proper policy with the way you're administering the medication through the tube. You always want to observe your rights, right patient, right dose, right route, right documentation, all of that when you're doing enteral feeding, and always be aware of the established protocols at your institution. We at Hunter teach you one way of doing the enteral feeding, which is an evidence-based way of doing it, but you definitely want to always go back to what does your hospital prescribe in terms of how they want you to do enteral feeding. So for all of you, when you're going to do an enteral feeding the first time at your place of work, check your institutional policy and make sure you're following the steps that they want you to follow to do it. Oral care is also very important with maintaining nutrition. Dental health is increasingly neglected with advanced age. Poor oral health is associated with dehydration, malnutrition, and systemic diseases. Oops. Again, guys, don't touch the slides. It's not reimbursed by Medicare. Fewer older adults have private dental insurance. Oral cancers are also more frequently occurring in later life. They occur more frequently in men than in women. Some of the risk factors include tobacco use, alcohol use, poor nutrition, HPV infection, and immunosuppression. Oral examinations help to assist in the detection and treatment of oral cancers. So you want to do a good physical exam on your patient, and as part of the exam, you want to assess their oral cavity, not only for things like lesions that could be cancerous, but just for part of their hygiene, and to make sure, as far as aspiration risk, that there isn't pockets of food in the mouth that need to be cleaned out. You want to be aware of their risk factors like smoking, and federal regulations actually mandate annual examination for long-term care residents. So again, assessment of oral hygiene habits, using an ultrasonic toothbrush can be helpful. Foam swabs are very helpful. Therapeutic rinses, like I use Biotine at my hospital for those who have dry mouth, but there's also Parawex, which is a Paradex antiseptic solution. Tube feedings are often associated with significant pathological colonization of the oral cavity, and that's because patients who are on tube feeds sometimes have their oral cavity neglected and not assessed quite as much when caregivers are not actually assisting in that oral nutrition. So making sure for your patients on feeding that you assess regularly their oral cavity. And oral care should really be assessed and provided every 4 hours as needed for patients with PEG tubes. Other interventions, patient and caregiver education on cleaning techniques, making sure that dentures are regularly cleaned and that they fit appropriately, especially for patients who have had significant weight loss, and commercial marking systems to identify dentures, especially in a residential setting, because they very easily and very frequently get lost. And as we talked about in one of our previous lectures, they're not easy to replace. They could be very expensive. And so this is the end of this part, and I literally finished just on time at 2:54, 1 minute to spare. So what we'll do is we'll go into our presentations, and we'll start with the vascular presentation, and then we'll do the cardiac presentation. So I'm going to pull up your slides, and I'm going to share your slides. And so take it away, vascular group. Whoops. Come out of here. We'll go here. We want to share. cardiovascular. Oh no, we wanted vascular to go first. Here's vascular. Let's share that. Okay, there we go.
Okay, guys, this is Jasmine speaking. Is my group here?
Yes.
Yeah? Okay. So I'm Jasmine. Can everyone introduce themselves?
I'm Alex.
I'm Sue.
Joey! Okay, so also Joey's in our group. Okay, so we're going to be covering vascular changes in the geriatric population. Okay, let me just. Okay, so talking about aging blood vessels, there are three main changes that occur. First, there is decreased sensitivity of the baroreceptors. So, as you guys probably remember, baroreceptors are found in the carotid sinus and the aortic arch, and they sense changes in blood pressure and modify the sympathetic and vagal activity to prevent excessive rises or falls. When the body moves to a standing position, our baroreceptors detect the subtle drop in blood pressure caused by gravity, which causes blood to pool at our legs, and almost immediately the sympathetic system should be stimulated, causing vasoconstriction, increased heart rate, and increased cardiac contractility. So older persons with baroreceptor failure may experience orthostatic hypotension because of the failure to do so. And the second, arteries also become thicker, stiffer, and less flexible with the loss of elasticity. And this puts individuals at greater risk for hypertension and also arterial sclerosis. The third thing, capillary walls thicken, and this means a slower exchange of gases, nutrients, and waste between blood and body tissues.
Hello, can you guys hear me?
And this is Joey gonna present orthostatic.
Okay. Jasmine, you can hear me, right?
Yeah, I could hear you.
Okay, sorry. So the first condition we're going to talk about is orthostatic hypotension. Orthostatic hypotension is defined as a drop in systolic blood pressure of at least 20 mmHg or a drop in diastolic blood pressure of at least 10 mmHg within 3 minutes of standing. So orthostatic hypotension occurs in 30 to 50% of elderly persons with disease and or medication risk factors such as polypharmacy. Some typical symptoms including dizziness and pre-syncopes. There are also atypical symptoms such as neck pains, and some elder adults can experience no symptoms at all. This condition increases the risk of fall, syncopes, and increasing hospitalizations. Going on, we have aging and hypotension. So some mechanism behind why older people has an increased risk of hypotension. So as studies have shown that diuretic-induced dehydration or drug-induced vasodilation causes greater blood pressure declines in elderly compared with younger patients. Since the arteries and arterioles are less elastic, blood pressure cannot adjust quickly when people stand, and older people are at risk for dizziness and in some cases fainting when they stand up too quickly. Also, postprandial hypotension, which is the blood pressure declines of at least 20 mmHg within 1 hour of eating, commonly occur in older patients as well. And last but not least, cerebral blood flow declines with increasing aging. So the next slide, we are talking about some nursing implication that we can do with patients who are experiencing orthostatic hypotension. So the goal here is to improve patient functions, independence, and well-being, and to prevent future complications during acute illness or if the hypotensive stressor occurs. We want to assess the risk of injury so we can implement fall precautions, such as by placing call lights next to patients, or remind patients to call for help before getting out the bed, or having the patient wear their non-slip socks. We also want to instruct the patient to take their time when changing from lying to standing positions. When getting out the bed, they can take some time to sit on the edge of the bed for a minute before actually standing up. Okay, so the next slide for hypertension, I think Alex, you can take over.
Yes. So just some info that everyone probably already knows about hypertension. It's the most prevalent cardiovascular disease in older adults. And hypertension diagnosis requires a consistent BP reading of 140 over 90 or greater. So, you know, make sure the older adult hasn't just had like a big coffee and was speed walking to their visit, or they don't have white coat anxiety, since those things could like give a temporary high reading. And also that aging is the biggest risk factor for hypertension, which we know is a non-modifiable risk factor and is a greater risk than things like smoking, not exercising, diet, etc. So because the other group is covering cardiac changes, I'm going to try and stick to the vascular changes and their role in hypertension. So the large arteries, like the aorta, for example, are rich in elastin and collagen, which help to sort of buffer the intermittent output from the heart to create a steady flow to the capillaries. And during the aging process, this collagen and elastin begins to break down, which affects blood flow to the coronary arteries and the rest of the body, and it increases the cardiac work. So there's evidence that this causes increased cardiovascular risks, which include hypertension, and also this loss of elasticity in the large vessels has a larger impact on older adult hypertension, whereas with younger people, blood pressure is more determined by peripheral vascular resistance. There's also a change in endothelial function with aging, and the endothelium produces nitric oxide, which is a vasodilator, and endothelin, which is a vasoconstrictor and procoagulant. And this changes the structure and function of the arteries. So, and when we age, there's increased production of endothelin and decreased production of the nitric oxide, which promotes vascular smooth muscle growth and a procoagulant state. So when you have hypertension, this process becomes like super exaggerated, thereby putting you at more increased risk for cardiovascular events. And then this is sort of just like an image that sort of shows what the process of decreased production of nitric oxide by the endothelium does over time. You can see that if this process is allowed to continue unchecked, it can cause like a huge buildup of plaque that could potentially rupture, causing an MI. And then, so signs and symptoms of hypertension in older adults. We all know that it's referred to as the silent killer, because much of the time, if you're getting the symptoms like dull headache, confusion, nosebleeds, and target organ damage, then the hypertension has often gone unnoticed for a really long time, which is, again, why primary prevention is so important. And then on this slide, this is just sort of like an easy way to show some of the target organ damage that can occur when hypertension goes unnoticed. So you have like vascular impacts like the endothelial dysfunction, stenosis, aneurysms, as well as cerebrovascular damage like stroke and vascular dementia, and then heart disease, chronic renal insufficiency. So for an audience question, probably pretty easy. Older persons with hypertension have a higher risk for all following events except, and you can just type it if you know the answer. A, acute renal insufficiency. Yes. Yeah, so yes, older adults with hypertension are at risk for chronic but not acute renal insufficiency. Good job, guys. Atrial fibrillation might occur in people who have it, failure, as well as acute cardiovascular and cerebrovascular events can occur in people with hypertension, and MIs too. And so, what does that mean for us as nurses, like what we can do? Obviously, the best thing, which we've learned all throughout school, is primary prevention is clutch. Making sure older adults are seen regularly by a primary care practitioner and are engaging in healthy lifestyle practices. And if they have like comorbid conditions that could cause hypertension, like diabetes, making sure that all of those conditions are under control to decrease their risk. And then being able to catch hypertension early is obviously best for older adults and the elderly, because jumping into aggressive pharmacologic treatment is not advised for older adults because of risks of hypotension, like we said before, and drug interactions due to polypharmacy and the metabolic changes that affect drug absorption as we age. And so the first step, the first step is always the non-pharmacological interventions. So like DASH diet and other low salt and low fat diets, exercise, even just going on walks, yoga, meditation, smoking cessation if they're smokers. So for pharmacological interventions, thiazide diuretics are normally the initial treatment. And as you know, with those, you're going to have to monitor for things like hyponatremia, hypokalemia, and acute renal injury, and as well as like thinking about whether or not your patient has impaired mobility, since obviously we don't want them like falling as a result of rushing to the toilet to void. And whether they have a caretaker or maybe they will need one as a result of that. And then if that doesn't work, then you move on to things like beta blockers, calcium channel blockers, and ACE inhibitors, obviously taking into consideration the individual patient's needs and comorbidities before prescribing. So since there's evidence that drugs like beta blockers can be harmful for people over 60, it's really important to make sure to modify behaviors and lifestyle first and trying thiazide diuretics before moving on to the more aggressive treatments. And then here's a case study, which I feel like is like more realistic in that it's very likely that patients will have comorbidities and other health issues that could affect hypertension. So a 62-year-old African-American woman presents for her annual physical exam. She has a history of hypertension and heart failure. Her blood pressure is 160/100 on thiazide diuretic therapy. She is obese with a BMI of 30 kilos per meter squared and waist circumference of 40 inches. Her estimated glomerular filtration rate is 46 milliliters per minute. An echocardiogram shows normal systolic function, increased left ventricular mass index with a concentric left ventricular hypertrophy and diastolic dysfunction. So for this patient, she's already on the thiazide diuretics, right? So what would be the next steps for treating this patient's hypertension? You can either or talk. So, and also think in terms of the diagnostic, maybe you want to exclude certain disorders that she might have, or exclude exams to exclude certain things. So maybe you want to exclude if she has thyroid disease. Yeah, good job, Carly. And maybe are there any other exams that could, yeah, so diabetes, and then excluding a cardiopulmonary exam to exclude signs of decompensated heart failure. And then what about, so if this patient, she obviously has had hypertension for a while, so what are some things that you might want to check for that if her hypertension has been going on for so long? Yeah, teaching the DASH diet, obviously she's still having issues with her diet, but like maybe an eye exam. Yes, good job. And then family history should be checked for cardiometabolic disorders. And then obviously, yeah, more aggressive pharmacotherapy. So what are some lifestyle changes that this patient could use? Yeah, definitely. And then you said the DASH diet before, obviously. Yeah, physical activity, exercise, restricting sodium, and then and also like maybe reteaching, making sure that like seeing if her family can help her with adhering to the treatment recommendations too. Yeah, perfect. Cool. So next, oh, someone else.
Um, Next, we have peripheral vascular disease. So there are 4 of them we're going to talk about today. Let's go on for the first one. It's the arteriosclerosis. Arteriosclerosis is a condition that it's defined as the formation and growth of plaque within the arterial lumen with concurrent loss of vascular elasticities. It's a process involved including coagulation, inflammation, lipid metabolism, internal injuries, and smooth muscle cell proliferations. So eventually, as we can see in this picture, this condition can lead to consequent blood flow reductions through the affected vessels, and it has also long been associated with cardiovascular disease-related death. The etiology of arteriosclerosis is still unknown, but there are multiple factors that contribute to arteriosclerotic plaque progressions. These include genetic and acquired factors. Obviously, aging is the dominant risk factors for significant arteriosclerotic lesion formations. And as you get older, your risk for arteriosclerosis increases. Genetic or lifestyle factor causes plaque to build up in your arteries as you age. By the time you are mid-age or older, enough plaque has built up to cause signs or symptoms. So in men, the risk increases after age 45, and in women, the risk increases after age 55. There are also some traditional risk factors, such as a lack of physical activities, smoking, hypertension, hyperlipidemia, and diabetes. So next we have the signs and symptoms for arteriosclerosis, and it is depend on the severity and the arteries that has been affected. So if the plaque has a buildup in the coronary arteries, then we can see patient experiencing angina, shortness of breath, arrhythmia. And then if it's affecting the carotid arteries, it can have the patient can have stroke. If it's partial obstructions, patient can experience confusions. If the obstruction is complete, patient can experience sudden numbness or weakness in arms, legs, difficult speaking, slurred speech, dripping muscle in face. Arteriosclerosis can also obviously affecting the peripheral arteries, can cause intermittent claudications or poor wound healing. Some of the nursing interventions, so we're focusing on adapting a healthy lifestyle. We can use medication or lifestyle changes to lower your blood pressure, lower cholesterol, lower your blood sugar levels, and preventing blood clots, blood clots can lead to heart attack and stroke, and preventing inflammations. Also to reduce risk factor in an effort to slow or stop the buildup of plaque, including quit smoking, exercising, and adapting a heart-healthy meal. So I include some of heart-healthy foods on the side, including salmons, avocados, walnuts, raspberries, and chickpeas. Also, lastly, we want to help patients to relieve their symptoms, such as control the pains that associate with this condition. Next, we have a questions for you guys. So which patient is at greatest risk of developing arteriosclerotic heart disease? Answer A is a 68-year-old female patient with a triglyceride level of 135 and a high density lipoprotein level of 68. B, a 70-year-old male patient with a total cholesterol level of 181. Yes, so it's the answer is C. Oopsie, made it too big. Oh, okay. Oh, sorry. Yeah, the answer is C. Because the triglyceride level is off the charts. Also the LDL level is higher than we wanted, so that can increase the risk of arteriosclerotic heart disease. Thank you, guys. So next, aneurysms. I think this is for
Okay,
Jasmine.
so aneurysm is another vascular condition that we may see in older adults, and it occurs when part of an artery wall weakens, allowing it to balloon out or widen abnormally. So the picture on the top right corner shows some of the different types of aneurysms. So advanced arteriosclerosis is usually responsible for the development of aneurysms in older adults because, as we mentioned earlier, as we age, there's plaque buildup in the vessels, which can change the properties of the vessel walls. And other causes may include infection, trauma, and syphilis. And some risk factors include a history of arteriosclerotic lesions, angina pectoris, MI, and CHF. So some aneurysms can be seen by the naked eye and palpated as a pulsating mass, while others can only be detected through radiography. Okay, so there's two types of aneurysms. There's the aortic one and the peripheral one. And for the aortic aneurysm, we see a thoracic aortic aneurysm. So we may see tenderness or pain in the chest, back pain, hoarseness, cough, and shortness of breath. And abdominal aortic aneurysm, AAA, is actually the more common one we see in older adults. And the signs and symptoms include pain in the chest, abdomen, lower back, or flank. And we may also see a pulsating mass when you palpate over the abdomen. And those who are at most risk include men over 65 years old, white men, smokers, family history of AAA, hypertension, and hardening of the arteries. And for the peripheral aneurysms, there's the mesenteric ones, the renal ones, and aneurysms in the leg. So for mesenteric aneurysms, we can see stomach pain and feeling full soon after eating. And for renal aneurysms, we can see uncontrolled high blood pressure and flank pain. And aneurysms in the legs, we can see claudication, weakness or numbness in the leg, and painful or discolored toes. Okay, so the main complication for aneurysm is aneurysm rupture. And it's a medical emergency, particularly if it's an aortic aneurysm, because it can cause life-threatening bleeding, as you can see in the picture, the third picture. When there is a rupture, there will be sudden severe pain and hemorrhagic shock. So it's important to monitor our patient for signs and symptoms of shock, such as quick shallow breathing, cool clammy skin, tachycardia, and hypotension, so we can intervene immediately. And on the other hand, some aneurysms may never rupture. And for small ones, we may monitor it, but if it's too large, it may need surgical repairment, such as clipping, endovascular grafting, and stent. And another complication is the formation of thrombus, which may lead to tissue ischemia and limb loss. Okay, some nursing interventions we want to do is we want to monitor vital signs. We want to check for circulation, such as their pulse, their temperature, and color. We want to observe for signs of rupture, note any abdominal tenderness, and monitor for abdominal distension. For peripheral aneurysms, we want to prevent thrombus formation, so we can give anticoagulants and promote physical activity. And it is also important overall to educate the patient about the modifiable risk factors to lower their risk of developing aneurysms and promote healthy blood vessels, such as if they have hypertension, we want them to control their blood pressure. We want them to maintain a healthy diet, get regular physical activity, we want to do smoking cessation, and manage stress. Okay, so there's a question for you guys. So during an assessment of a patient's abdomen, a pulsating abdominal mass is noted by the healthcare provider. Which of the following should be the healthcare provider's next action? A. Ask the patient to perform the Valsalva maneuver. B. Obtain a bladder scan. C. Measure the abdominal circumference. Or D. Assess femoral pulses. Okay, yes, the answer is D. So, a pulsating mass may indicate the presence of an abdominal aneurysm, and if we assess the pulse aneurysm, it will provide information regarding the degree of circulatory compromise. Okay, next topic, varicose veins.
Okay, guys, so varicose veins is a common sighting seen in older adults. They are twisted, enlarged veins that indicate weak or damaged vein walls and or valves. As you can see on this slide, on the right, the valves don't close properly and blood can flow backward and pool in the vein. Causes include lack of exercise, standing for long periods of time, which is something we might have to worry about in the future, loss of vessel elasticity, and strength associated with aging. Usually they're nothing to worry about and are benign. However, if venous stasis becomes a bigger problem, these veins can be removed through ligation and tripping. As nurses, we should be aware that these patients may experience orthostatic hypotension because of pooling of the blood in the lower extremities. Due to venous insufficiency, they're also at a greater risk for stasis ulcers, as you can see in this picture below. These ulcers are characterized by pain, edema, skin color, and texture changes, usually in the lower leg. Because the skin is more susceptible to trauma and infection, you have to be more mindful of keeping these areas dry and intact. To promote optimal circulation, we should advise these patients to avoid prolonged sitting, standing, and crossing of the legs, to elevate their lower extremities when sitting, to avoid tight clothing or tight bandages of any sort that constricts, and also to engage in exercise. Our last topic is on venous thromboembolism. This occurs when a blood clot forms in a vein breaks off and becomes lodged in a smaller vessel, thus blocking blood flow. Risk factors can be grouped by hypercoagulability, injuries to endothelial cells and blood vessel wall, and also the stasis of blood flow. Now, older individuals are at a greater risk for malignancy, more likely to use hormone replacement therapy, such as postmenopause. They're at a higher risk for bone fractures and may undergo major surgery for a number of acute and chronic conditions. You might also see congestive heart or respiratory failure in these patients, spinal cord injury, as the the cushioning between the spinal column diminishes, also immobility and or dehydration. Okay, so two major blockages that can occur are DVTs and PEs, pulmonary embolisms. So with DVTs, there are some signs that will help you differentiate from other conditions. Comparing the affected leg to the non-affected leg, you may notice swelling and tenderness, skin discoloration, and that the skin is warm to touch. You can see in this picture, it's very boggy. Also, with pulmonary embolisms, the patient may experience shortness of breath, cough, chest pain, sweating, rapid heart rate, and hypotension. Nursing implications. So ideally, you want to prevent a venous thromboembolism before it occurs. You want to avoid venous stasis. You want to promote active leg exercises, early ambulation. Some people can prophylactically wear compression stockings. You put them on before you get out of bed. And also, if you're on bed rest, they might order you some sequential compression devices. You may see these in patients after surgery. Also, you might want to do pharmacological prophylaxis with anticoagulants. Treatment for the blood clots, analgesics to relieve pain, anticoagulants, thrombolytics, and surgical embolectomy. So we have a case study right here. I'm going to read this to you. Mr. Luke is a 68-year-old Asian male with a history of smoking 1 pack of cigarettes per day. He is currently a client on an outpatient rehab unit following a left total knee replacement 5 days ago. This afternoon, during physical therapy, he complained that his left leg was unusually painful when walking. His left leg was noted to have increased swelling from the prior day. He was sent to the ED to be examined. Mr. Luke's vital signs are 98.1 degrees Fahrenheit, pressure 110 over 50, pulse 65, respiratory rate 19. His O2 stat is 98% on room air. D-dimer is 7 micrograms per milliliters. Physical exam reveals that his left calf circumference measurement is 3/4 of an inch larger than his right leg calf circumference. Mr. Luke's left calf is warmer to the touch than his right. What procedure will Mr. Luke need to have done to rule out his DVT in his left leg? So we're going to talk about a diagnostic test. Is anyone familiar with this? Yes, great, Carly. Yes, so the diagnostic for this would be the Doppler. It's a imaging test with the ultrasound. They'll use something specifically with the called the duplex, which helps with identify look through the arteries and the veins. I also have blood tests for measuring blood clot degradation products as well. You can do that. For the second question, the healthcare physician in the emergency department chooses not to assess him for the positive Holman sign. Why is it not used? Carly also answered that as well. It's not sensitive enough. That's correct. The accuracies might only just be 50%. Also, there's a bit of controversy because it can also dislodge the clot, which is obviously very dangerous. DVT. So his leg is swollen, it's painful, it's warmer to the touch. There's many indicators right here. Discuss interventions, non-pharmacological or pharmacological, that the nurse should include in a post-surgical plan to help reduce the risk of DVT. Like we mentioned before, early ambulation, as long as it can be tolerated. Compression devices, anticoagulants, all those things can be included in the care plan. And right here, these are our references. You guys could look through that if you want. And that's about it. Does anyone have any questions? Okay, thank you. Okay, that's at the end of our presentation.
Thank you.
Great job, guys.
Thank
Great job,
you.
guys. I'm gonna queue up our next group, cardiovascular, and I'm gonna share your slides, and
Great. Hi, can everyone hear me?
Yes, I can hear you.
Oh, okay, perfect. Sorry about that. So I'll just start by introducing everybody. My name's Monica Zabaklitsky. In this group, we have Sandy Lei, Crystal Wen, Dana Wu, and Xing Zhu, and myself. So the prior group did a pretty, I guess, similar topic to ours. They focused more on the vascular changes, which are, further from the heart. And we're focusing on most of the cardiac changes that occur as we grow older. And we're going to start with just an overview of the cardiovascular system. So I'm handing that off to...
It'll be me, Dana, who will be speaking on the cardiovascular system for the overview, right? So, the cardiovascular system, it circulates blood around the body, and the cardiovascular system, it mainly consists of the heart, blood, and the blood vessels. As you can see on the picture to the left, is the heart and some arteries in relation to where the body and where all these parts are located in the body. And to the right is a picture of the heart. So as you know, the heart is like a pump that moves blood through vessels. It has two chambers. The main function is the transport of inhaled oxygen from lungs to body tissues and the removal of CO2 from body tissues to lungs to be exhaled. And in terms of blood flow, oxygen poor blood returns to the right side of the body, the right atrium, then goes to the right ventricle, to the lungs, to the left side of the body, to the left atrium, to the left ventricle, and through the aorta to the rest of the body. Next slide is this is more details about the heart, and it shows you the picture shows you the layers of the heart. Layers of the heart starting from the innermost layer. The innermost layer is is called the endocardium. Then there's the middle layer of the heart called the myocardium, and then there's the epicardium, which is the external layer of the heart. There's also the pericardium. It's the membrane that surrounds and protects the heart. It's composed of two layers and a cavity. The inner layer is called the visceral pericardium or epicardium, and the outer layer is the fibrous pericardium. And the cavity in between is called the pericardium cavity, which holds fluid that serves as a lubricant. And as was said before, for this presentation, we'll focus on changes that occur to the heart, while the vascular presentation focused more on peripheral vascular changes. However, some topics that do overlap in both of our presentations. I'll talk about, I'll be talking here about some of the changes that some general changes that go along with aging. So as we age, organs in our cardiovascular system go through various changes, and most of these changes are usually gradual, and they become more apparent in periods of stress. So one change is that the heart valves increase in thickness and rigidity. This is due to sclerosis and fibrosis. Sclerosis is the hardening and thickening of body tissue. The aorta also becomes dilated. The left ventricular wall thickens, and there's slight ventricular hypertrophy. Hypertrophy is when there's becomes thicker with tissue. There's also decreased efficiency of the myocardium. As we age, the myocardium loses some of its contractile strength, which causes a reduction in cardiac output when the demands of the heart are increased. There is also there's more time is needed for dialytic filling and systolic emptying. In addition, the heart becomes less sensitive to baroreceptor regulation of blood pressure. Receptors located in the aorta and respond to changes in blood pressure. A higher blood pressure causes heart rate to decrease and blood pressure to decrease, while a decreased blood pressure decreases baroreceptor activity and causes the heart rate to increase and restore blood pressure levels. In addition, there is also the increased risk of altered tissue perfusion. This is due to conditions such as cardiovascular disease, diseases such as diabetes, and blood dyscrasia such as anemia. Some more cardiovascular changes are continued on the next slide. Another change is that there is longer and less forceful contractions. This is related to a decrease in enzymatic stimulation. There's also decreased peripheral circulation. This is associated with an increase in oxygen demands of coronary arteries and the brain. Some other changes are the loss of elasticity of vessel walls, a decrease in contraction by the heart, which is due to a decrease in the contraction of the heart to compensate for coronary artery. There's also the reduced or unaltered heart rate at risk, mild tachycardia on activity, and as we age, there's also a slow increase in serum cholesterol. I included a picture of some changes that happen to the heart as we age. In the picture, I'm not sure if you can tell, but the left is a normal heart, and to the right is a heart that ages. So some notable changes you can see is the hypertrophy of the heart. There's increased thickness, and thank you, and some other changes you can see is that there is a buildup of atherosclerotic plaque, and some other changes that are more detailed. Going on to the next slide. I've included a practice question. It reads, an older patient has been diagnosed with a venous thromboembolism. Which age-related change most likely contributed to this diagnosis? Is A, decreased coronary blood flow, B, less efficient cardiac oxygen usage, C, decreased elasticity of blood vessels, or D, increased resistance of peripheral vessels? All right, I got some answers. Yes, it is C. There's decreased elasticity of blood vessels. That's one change that happens as we grow older. Because of this elasticity, this contributes to the pooling of blood because the vessels lose their elasticity. And addressing the other choices, a venous thromboembolism is not likely to occur because of decreased coronary blood flow, less efficient cardiac oxygen use, or increased resistance to peripheral vessels. So as we age, there is an increased incidence of a variety of conditions. So one of them is hypertension. Hypertension is the most prevalent cardiovascular disease of older adults. And so what is considered hypertension? Well, hypertension is considered when you have a systolic blood pressure greater than or equal to 140, diastolic blood pressure greater than or less greater than or equal to 90. Results from vasoconstriction with aging, and this produces peripheral resistance. Some signs and symptoms of hypertension is awakening with a dull headache, impaired memory, disorientation, confusion, epistaxis, and slow tremor. And in terms of diagnosis, hypertension is usually diagnosed when the client is having a routine examination or when related complications have already developed. Um, so nurses should try to carefully assess the patient's blood pressure by checking it several times with the patient in standing, sitting, and prone positions. And so the treatment is generally rest, low sodium diet, and weight reduction. And the blood pressure goal is 120/80 mmHg. And another condition that we see in older adults is hypotension, which is a decline in systolic blood pressure greater than 20 mmHg. Um, there's two different types of hypotension. So after rising or standing for 1 minute is called, while the other one is within 1 hour eating, you experience this decline. It's called postprandial hypotension. So um, signs and symptoms are dizziness, confusion, syncope, restlessness, drowsiness. Hypotension increases the risk for falls in older patients, and it can lead to stroke, syncope, and coronary complications. Some age-related factors include an increased intake of vasoactive meds and a decrease in physiologic function. Another condition we see in older adults is congestive heart failure. And what congestive heart failure is, it's like a weakness. Uh, oh no. How do I zoom out? Wait, there you go. And it's a weakness of the heart that leads to a buildup of fluid in the lungs and the surrounding body tissues. It's also the leading cause of hospitalization of older adults. And some risk factors include coronary artery disease, hypertension, diabetes, and dyslipidemia. Age-related factors that do lead to congestive heart failure include reduced elasticity and lumen size of vessels, increased blood pressure. Some signs and symptoms include dyspnea on exertion, which is the most common finding, confusion, and insomnia. Um, you also see some other symptoms such as weight gain and bilateral ankle edema. On auscultation, you hear moist crackles. And the management of congestive heart failure is bed rest, ACE inhibitors, beta blockers, digitalis, diuretics, and a reduction of sodium intake. And the risk of skin breakdown is very high in patients with chronic heart failure due to edema, poor nutrition of tissues, and fragility of older skin. So skincare is very key to reduce skin breakdown in congestive heart failure. We also see pulmonary emboli. Risk factors. Pulmonary emboli, first of all, is a blockage of the artery and lungs by a substance that has moved from elsewhere in the body through the bloodstream. And some risk factors include fractured hip, chronic heart failure, arrhythmias, and a history of thromboembolism. Some age-related factors that lead to pulmonary emboli include increase in incidence of immobilization and malnourishment. Some signs and symptoms in the older adult include confusion, apprehension, increasing dyspnea, slight temperature elevation, pneumonitis, and an elevated sedimentation rate. And many older adults may not experience pain due to an altered pain sensation. And diagnosis through a lung scan or angiography. And the treatment for pulmonary emboli is the same for young adults. It's anticoagulation therapy, fibrinolytic agents, pulmonary embolectomy, and inferior cava filter. And we also see hyperlipidemia, which is and elevated total cholesterol. It's associated with coronary artery disease, which I'll talk about next. Its risk increases with age due to increases in low density lipotension, and some age-related factors include increased incidence of lipoprotein disorders such as uncontrolled diabetes and hypothyroidism. Diagnosis is through a full lipid profile, and the initial treatment is diet and exercise. Meds are used afterwards if diet and lifestyle modifications alone do not bring about results. Some medications you can use are statins and bile acid sequestrants. Next will be coronary artery disease. So coronary artery disease is also known as ischemic heart disease. Coronary artery disease is when the arteries that supply blood to heart muscle become hardened and narrowed, and the prevalence of this disease increases with age. At length, I'll talk about both angina and myocardial infarction. So both are clinical manifestations of coronary artery disease. Angina is also known as chest pain. It's a symptom of myocardial infarction, and it presents in an atypical pattern in older adults. For um, for I only have yeah. So for coronary artery disease, is like so a symptom is a symptom of myocardial infarction. It presents in a atypical pattern in older adults. For this, the pain is diffuse and less severe. And for older adults, the pain is diffuse and less severe, and the pain might progress to precordial pain radiating down left arm. And the treatment for this is lower dose nitrates due to risk of orthostasis and myocardial infarction. It's frequently seen in older adults, and it presents with atypical symptoms and the absence of pain. Some signs and symptoms include chest pain, which is but it's less common because it's often confused with multiple comorbid conditions. And some other signs and symptoms include pain perception, which is reduced in older adults. Dyspnea is more frequent, and treatment for myocardial infarction includes early ambulation post MI, thrombolytic therapy, and so for older adults, you need to closely monitor for bleeding. For patients who are on thrombolytics. And finally, the last condition I'll be talking about is arrhythmias. So the causes are digitalis toxicity, hypokalemia, hemorrhage, and Geno syndrome. Digitalis toxicity is the most common cause, and some signs and symptoms include weakness, fatigue, palpitations. Treatment is based on the type of arrhythmias. So it can be tranquilizers, antiarrhythmic drugs, digitalis, all based on which type of arrhythmia that you have. Atrial fibrillation is the most common chronic cardiac arrhythmia. Most patients affected by this are over 65 years old. Risk factors for this is arch structural defects, comorbidities, hypertension, and the treatment for this is antiarrhythmics, electrocardioversion, catheter ablation, and Mays procedure, which is surgical ablation. Next, we'll be moving on to the case study.
Dana, I'm going to take over the case study. Okay, for the case study is going to be for Jason Addison. He's 72-year-old man, and we're just going to skip the case study for now because it looks like we're running out of time. So I'm just going to go through my part pretty quick. For mine, it's going to be risk factors. And of course, the vascular group already talked about it. And it's going to, for the older population, old age is a risk factor. Family history, of course, South Asian, African, Caribbean descent, and high blood pressure, unhealthy blood cholesterol levels, diabetes, obesity, smoking, lack of exercise, and low socioeconomic status. Like all of these are all risk factors. And now I have a case study. I'm just gonna read like the important stuff, and you could just like type in the answers. You just tell me what are the risk factors for Mr. Addison. He has a history of hypertension, hypercholesterolemia, COPD, type 2 diabetes, and he was admitted to a hospital a year ago for MI, and he's been smoking 10 cigarettes for 10 days. 10 cigarettes a day for 25 years, and he says he stopped a year ago. So, what are his risk factors? You just type it in or raise your hand, whatever works. You don't have to read the whole thing. It's just like his history. Yep, smoking. Yeah. Anything else? Yep, hypertension. Good. Just and then also he has hypercholesterolemia. That's also unhealthy. Yeah. Yep. Okay, and I guess that's it for him. And then cardiovascular disease. Yeah, also that he's inactive. He needs exercise. Cardiovascular disease, it's one of the main concerns, so it's very important to get a history of what's going on with them. And I think the most important point is just to make sure that their habits during their early lifestyle can carry on to their when they're older. So it's very important to teach them when they're younger, even if they're like 40 or 50, and then it carries on to later when they're older. And I guess some important practices to reinforce things that that they can change to make sure that they're healthier is proper nutrition, getting enough exercising, smoking cessation, and stress management. Especially right now, we could all use a little bit of stress management. Just make sure you breathe, sleep, socialize if you can, and just a little bit of activity. And then I just have a little bit of what is proper nutrition here. No fried foods, of course, animal fats, such as fast foods, increase your complex carbs and fibers, and then use whole grain products. Also maintain a calorie count of around 2,000 a day, and just try to not take as much like red meat, sugar, highly processed foods, and just limit alcohol, of course, if you can. And then you could, a lot of older adults also take nutritional supplements. Here's a list of them. There's vitamin B6, vitamin B12, and vitamin C, selenium, magnesium, calcium, chromium, potassium, fish oil. And the ones that we see a lot is vitamin B6, vitamin C. And what it does, vitamin B6, it helps with heart attacks, strokes, and prevents homocysteine-induced oxidation of cholesterol. There's a lot of other nutritional supplements they take too, like potassium, reducing reliance on antihypertensives and diuretics. And we also see a lot of patients taking fish oil, which reduces coronary artery disease deaths and lowers blood pressures. I guess you guys could also look over the other ones, but since we're running out of time, I'm just gonna move on to what nurses can do to help with these modifiable risk factors like exercise. Not everyone likes exercise, so what can you do? You could just tell them instead of taking the stairs, instead of taking the elevator, they can take the stairs, or just parking their car further away and walking there can also, little things add up, and walking more than, calling Uber, Lyft, or a taxi. And then, but the best thing would be encourage them to do at least exercise 5 days a week, at least 20 minutes of exercise. And then what can we do for smoking cessation and stress management? You can't just tell them to stop smoking and expect them to stop smoking. It has to be a gradual process. So you just want to refer them to some sort of support system, like smoking cessation programs. Sometimes acupuncture can help, and just keep being there for the patients, provide them encouragement, and also like tell their family members. That also helps a lot. And stress management is just something, yeah, it's just it's just things that we've been doing: exercise, yoga, meditation. Okay.
Whose part is this? Is this Jing's?
Yeah, Jing, I think so.
Okay. Jing?
Jing, we can't hear you.
Okay.
Okay, well, this is just an
Well,
example
Jing
for
can jump
cardiovascular.
in. I'll start with nursing interventions, and then Jing will jump in when her mic is working, if that's okay. So we're
Yeah.
just gonna skip a few slides into nursing interventions. So I'm kind of going to go back to what the vascular group was saying. Prevention is key, right? You want to think of primary prevention, which is preventing the development of illness. So you want to educate patients on exercise, healthy eating, nutritional supplements, and monitoring their blood pressure. Secondary prevention, what do you do once they have high blood pressure? You keep doing what you did in primary prevention, except now you want to look at medication adherence and compliance. You want to monitor for chest pain or other symptoms of potential MI or CAD. For tertiary prevention, the example I'd like to use is that you've already had, like you have high blood pressure, you've had an MI. How do you rehabilitate from this MI, right? So you're going to teach them new ways to exercise. Like you want to, kind of rest if your chest starts hurting and then start exercising again after that. You want to watch out for shortness of breath and things like that. So just to do a quick overview by disease, for hypertension, you're going to want to look at that DASH diet that everyone's been talking about, low fat, low salt. You don't want to go to medications first. You want to look at yoga and relaxation, primarily just to lower blood pressure a little, and because we're looking at a geriatric population, so we don't want to have many side effects. You want to make sure that in hypotension, you teach safe position changes. Hello? Sorry, I thought I heard someone. All right, so for congestive heart failure, you're going to look at a lot of symptoms of edema. You're going to look at difficulty breathing. For pulmonary embolisms, you're going to want, and again, there's so many, for all of these conditions, there's so many medications that you're going to need, but nursing interventions are going to be a lot more supportive, like help the patient ambulate, or even in coronary artery disease, like I was mentioning with MI rehab earlier, you want to educate patients and help them develop a sense of control. For hyperlipidemia, again, it's a DASH diet, and for arrhythmia, it's preventing an MI through DASH diets and also kind of knowing the symptoms. So you're going to want to encourage your patients a lot. And I think next we're looking at a case study.
Okay, so a few interventions. So what do you guys think are the interventions for Mr. Addison? Okay, so a few interventions in the hospital setting will be vital signs, INOs, O2 therapy, daily weights. You want to elevate the head of the bed to expand the lungs to reduce dyspnea. You want to make sure he's adhering to his drug regimen. You want to include rest activity periods. You want to consult with a dietitian. So you have to incorporate the patient's cultural food as well as their diet history. Most of the time, patients with heart failure will be on a DASH diet or a low sodium diet. You want to take into consideration physical and occupational therapy so that patient can maintain their ability to function. You also want to assist with coping and comfort, and as well as you may want to consider palliative and end-of-life care for those patients with heart failure who are in the severe and late stages. So most of these, so again, what should the nurse consider prior to discharging the patient? Most of these interventions can be carried out to outpatient settings, such as the medication, the resting during activities as well. And also you may want to encourage and help the patient apply for outside assistance, such as a home health aide to assist him with activities of daily living. Okay, and we can go back to the assessment now.
Oh, I'm sorry, guys. We're actually out of time, only because I do want to go over the exam with the rest of the group, and I don't want to hold people too long. But
Okay,
great
well,
job,
thank
guys.
everyone so much for your patience and for listening.
Absolutely. Great job. You did a thorough job. I'm sorry we couldn't get Jing into the conversation, but don't worry. Everybody will get credit from your group for putting in such hard work into the assignment. And again, I'm sorry we had to cut you off a little bit early. So if you have to go, I totally understand. Again, this is a recorded session, but I did just, for those of you who can stick around, just want to quickly go over exam 2, the written assignment. So the, let me just pull up the documents here. So it is, these are all posted on Blackboard in the exam content folder. There's a separate folder for exam 2, but basically what it is a teaching plan. You've all done care plans before, and this is very similar. The biggest difference here is that it's a plan for how you would teach a patient or their caregiver about a specific topic. And so I do want you all to select a topic from the second half of class. And that's everything from, I believe, intimacy, mentation, depression, anything from cardiac and nutrition that we covered today, and even death and dying from next week. And you're basically going to summarize what's the importance of the need, how you would teach the patient about this issue, whether you're going to do handouts, whether you're going to do video, whether you're going to have them do demonstration, maybe a combination of different methods, and you're going to talk about why you're choosing that method of teaching. You're also going to talk about what are some of the barriers you expect of learning given their age, like maybe then is going to be diminished. So a handout, you might have to adapt the handout for someone who might have diminished vision. The hearing or tactile sensation might be altered if they have neuropathy or, you know, whatever have you, or if they're sensitive to cold, you want to maybe make sure the room is temperate. Whatever you choose is fine as long as you can support it from literature, including your textbook. And then you're going to talk about different resources that you would share with the patient. Now, I don't want it to be a long paper. I really want it to be like a care plan. So I provided like a table that you can use. I would like it in a table format, and I provided a sample that you can all use. You're free to just use this and just change your information, but this is basically a sample of what I'm looking for. So what the learning need is, what the significance of that need is, and this is all going to be evidence-based, so you have to have a reference for it. It has to be within the last 5 years, unless it's the textbook. I haven't checked this most recent version of the textbook, so I apologize. But if it is earlier than 2015, that's fine. And I will update the rubric to reflect that. But I don't want it to all be from the textbook. I want you to use a variety of different sources to support your learning need and your teaching methods. And so in the second column, you're going to talk about what your teaching methods are. This is a fake one that I created for medication adherence in stem cell transplant, but are you going to do verbal? And then what the rationale for using verbal, handout, video, and then here it's multimodal, and I'm just kind of putting in some blah, blah, blah here about multimodal has been shown effective, and I would, of course, have a source for that. Then talk about your barriers. Now, when you talk about the barriers, I also want you in another line to address how you would address that barrier. So diminished visual acuity, I will use, you know, I will make sure that the font is greater. I will make sure that there's good lighting, whatever have you, but what the potential barriers are and how they would be addressed and how you would assess learning. So whether in this case it's medication adherence, I would have the patient demonstrate filling their pill box for me, and I would know that they understood their medications and how to fill the pill box accordingly. So something like shows you that they understood the teaching that you did with them. And then how you would communicate the plan. So where you're going to just document it in the nurse's note so that the next provider knows about it. Are you going to discuss it during team huddle? How are you going to, when you give shift report, you know, whatever your way of communicating your plan, and then also providing reference for what an evidence basis for why that's your chosen method for communicating the plan. You know, there's definitely evidence out there for handoff and that it's a great communication tool between nurses, but just definitely provide like in a one-liner in here why you chose that method, and then you know you're going to include your source and then just additional patient resources that you would share and the references. I didn't put a page length, but please have mercy on me. I'm going to be grading all of them. So try to keep it between, you know, no more than 3 pages if possible. If that's becoming a hardship for you and you're finding that it's, just email me and we can talk through that. I'm going to create an assignment page on Blackboard where you're going to submit this. It will be due May 4th by 11:59 p.m. And I also have a rubric for the assignment that shows you how grading is going to be done. Let me see, did I include that? Yeah, this is a rubric. I won't spend too much time going over it because it's pretty explanatory, but just take a look at it and it kind of gives you an idea of looking for from this assignment. So again, you have until from now until May 4th. The Blackboard page, I've created it. I just have to open up the link for those of you who want to just submit it early. So probably next week I'll have that opened up. And I see a question about it. Let me just come down here. Regarding the sample you provided, is it okay for us to be as concise as the sample? Yes, absolutely. Succinctness is key. I mean, as long as you hit all the key points, but definitely as succinct as possible is helpful because again, I'm going to be reading all of them. So definitely not a big paper. It traditionally was a paper that I would assign when I had a smaller group. So I've tried to find a way to adapt it to make it a feasible project for a larger group. So yeah, definitely, as long as you hit all the key points, being succinct definitely helps. And then the second part of your question, the format is similar to a care plan. Yes, so as long as we cite the APAs, we're pretty much, yes, exactly, yes. As long as you cite the APAs, you're okay. As I did in the sample here, at the end, definitely throw in a reference list right at the bottom with everything there. And then throughout the care plan or the teaching plan, you're going to have it like source sort of APA format. Does that make sense? I sort of blew through that quickly. Does that make sense to everybody? Very good. Are we creating a teaching plan for one learning need? Yes. So yes, one learning need, please. I think to try to do more than that and cover all these bases would just be too complicated for both you and to try to keep everything into this succinct little format. So just one learning need, but just, you know, if you want to, I think the better place to expand is not on adding more needs, but to give more teaching methods. So, you know, if you're going to do a handout, if you're going to do verbal, if you're going to do a video, if you're going to do demonstration, whatever have you, that's fine. But definitely just keep it to one learning need. And it has to be a learning need that's related to one of the topics we covered in this portion of the class. Okay, let's see. Any other questions? Thank you, Professor. I think it's good. Okay, great. So again, anything else that comes up, take a look at everything, read over everything. If anything comes up that's unclear, feel free to email me about it. You have from now until May 4th, as I said, at midnight. But the page where you're going to submit it, I have it done. I just have to open it. How many questions will be? No, there is no test, Frashian. This is the exam. You're going to be doing this teaching plan. So there is no exam, there is no questions. You're basically taking the content that you've learned in the second of the course and using your creativity to teach a patient or a patient family member about a topic that we learned in the second half of the course. Does that make sense? It can be any learning need, yes. Just confirm. It will be any learning need, yes, from after the first exam, yes. So anything that I taught from the second half of the class up until death and dying, which you're going to cover next week, You can pick any, even a subtopic within them. That's fine. If you want to do counseling about death and dying, if you want to do diabetes teaching, if you want to do intimacy teaching, if you want to do whatever you want, as long as it's something that's covered from the second half of the class, and as long as you hit all these points. And please feel free to use this template if that makes it easier for you. But please, a table format, not a paper. And then quickly, I'll just say for the extra credit, I hope that's going well and that you're all having a chance to meet and talk about the extra credit case study. So that will be next week. I'll have you all, those who participated, present, which I think is all of you. Nobody emailed me that they don't want to participate. So we'll carve out some time for you to talk through those case studies, because I really want to hear what all came from your conversations. I mean, you're a very bright and very vibrant group, so I'm sure that some really great conversation came from it. So I want to hear about that. And then at the end of the day, by 11:59, I just want one document from whoever was the recorder to be emailed to me with all of the names of the group participants on the one document, and I'll give you each your credit after I get them from you. So just make sure when you email me, whoever the recorder is, when you email me the document, make sure everybody on the team's name is on it, so that way they all get. Yeah, I think that's it. So if there's no more questions, the extra credit is due 4/20, so next week by midnight on 4/27. All right, so if there's no other questions, then have a great rest of the week, and we will all touch base in a week, okay? And then any questions, just feel free to email me. All right. All right, take care, everyone. Let me stop the recording.